You know, when you watch a disaster scene unfold on the news or when you see it dramatized in a movie,
Like a massive earthquake or something.
yeah, exactly, an earthquake or maybe a large-scale train derailment or a multi-vehicle pileup, there is this overwhelming expectation of just pure, unadulterated chaos.
Oh, absolutely. To the untrained eye, it looks like a complete breakdown of order.
Right, people are running, sirens are blaring, there's debris everywhere, and it just looks like panic. You assume the medical response is this frantic scramble.
Like they're just grabbing whoever happens to be closest, right? Or whoever's screaming the loudest.
Exactly. But it actually isn't like that at all, is it?
No, it really isn't. I mean, the sensory overload of a mass casualty event naturally tricks the human brain into perceiving a total loss of control. But when you look through the lens of specialized disaster response doctrine, that illusion of chaos completely shatters.
Which is fascinating. So what is actually happening?
Well, what is supposed to be happening when protocols are running correctly anyway is a highly orchestrated, deeply mathematical, and honestly, an intensely ethical matrix of decision-making.
And it's a matrix where life and death decisions are being made in, what, under 60 seconds per person?
Often much less than that, yeah.
Wow. Well, welcome to this deep dive. If you are joining us today and we know you love to learn, you love to dig into the why behind the way the complex machinery of our world actually operates, we have an incredible journey for you today.
We really do.
Our mission is to explore this high-stakes, intimately structured world of mass casualty medical triage. We are pulling all our insights today from comprehensive medical and military doctrine.
Specifically, we're analyzing a really definitive text titled Field Triage in the Military Arena by Miguel A. Cubano and Juan A. Asensio.
Right. And what makes this specific source so compelling is that it bridges the gap between the absolute worst environments imaginable, active battlefields, catastrophic natural disasters, and the very structured, sterile world of a hospital.
Yeah, we are going to break down exactly how medical professionals take a landscape of unimaginable destruction and essentially forcefully impose order onto it.
And just to set the parameters for you listening, our goal today isn't to hand you a scalpel, walk you through an anatomy textbook, and make you a trauma surgeon by the end of this deep dive.
As fun as that would be.
Right. But the actual goal is to give you the ultimate shortcut to being profoundly well-informed on how the absolute hardest choices in all of medicine are actually made.
Because when a hospital is suddenly faced with an exponential overnight increase in patients, personnel needs, and equipment demands, they have to decide who gets saved first.
That is the defining question of disaster medicine. And the answer rests entirely on the philosophy and the cold, hard mathematics of triage.
It does. And I think we should start right at the foundation, with the word itself.
I love that. I always find etymology fascinating because it tells you what the originators were actually trying to accomplish, you know?
Exactly. So triage comes from the French verb trier.
And that simply means to sort, to separate, to shift, or to select.
It sounds so mundane when you translate it, honestly. Like sorting laundry or separating grain.
Yeah, it really does.
But in a medical context, it is a rigid system of categorizing patients. And the vital thing to understand is that this sorting is not arbitrary.
And it's definitely not based on who arrived at the hospital doors first.
No, absolutely not. You are categorizing them based on a very specific intersection of data points. You look at the physical severity of their injuries, their statistical likelihood of survival, and
This is the part most people forget, a strict accounting of the exact resources you have available in that specific minute.
right, because, I mean, if you have a world-class surgical suite, but say the grid is down and you have no electricity, your triage math changes instantly.
Okay, let's unpack this. The prevailing dictum in all of these protocols, the guiding North Star of triage is, do the greatest good for the greatest number.
Which sounds incredibly noble. It sounds like
Yeah.
a philosophical ideal we can all agree on.
But putting that utilitarian philosophy into practice is a staggeringly brutal process, isn't it?
It is. It is not just a doctor standing in a room pointing at people. It encompasses the speed of on-site rescue, the logistics of the evacuation chain,
The receiving hospital's structural preparedness.
yes, and even the decontamination process. If you're dealing with, like, a chemical or biological threat, I'd actually take that a step further.
How so?
Well, proper mass casualty triage demands that we completely abandon our everyday normative medical ethics.
Wait, really? Abandon them entirely?
Yes, on a normal Tuesday, medical care is entirely patient-centric. The doctor focuses 100% of their resources on the individual in front of them, doing everything scientifically possible to save that one life.
Right, the standard of care.
But in a mass casualty event, that individualized focus becomes a fatal error. You have to shift from patient-centric care to population-centric care.
Because if you ignore the exponential needs of the crowd to save one incredibly critical individual, you prevent the logical allocation of your limited resources.
Exactly. And as a result, more people die.
So, if the system is designed to save the population, I'm guessing there are mathematical ways to measure when that system fails.
There are. And looking at the operational data, triage fails in two very distinct, measurable directions.
Under triage and over triage. I want to spend some time here because understanding these two concepts is kind of the key to everything else we were going to talk about today.
They really are the twin pillars of triage statistics. Let's tackle under triage first.
Okay, what does that look like operationally?
Operationally, under triage is a failure of sensitivity. It means the system failed to identify a severely injured patient who required immediate life-saving intervention.
So you looked at someone, categorized them as safe to wait, but they were actually, say, bleeding internally.
Right. And they deteriorated or died while waiting.
You missed the critical patient. The system essentially generated a false negative.
Precisely. And the flip side of that equation is over triage. This is a failure of specificity.
So over triage is the inefficient use of your highly specialized staff and resources on non-critical patients.
Yes. These are people who were flagged as needing immediate urgent surgery. They were rushed in with sirens blaring. But clinically speaking, their injuries were stable.
Meaning they could have safely waited hours without risking their life or their limbs.
Exactly. So over triage generates a false positive.
You are burning through your limited blood supply, tying up your only available trauma surgeon, and taking up a precious operating room for a patient who, in reality, wasn't in immediate danger.
Now here's where the math gets genuinely surprising.
I love the math part.
In normal, day-to-day civilian trauma care, organizations like the American College of Surgeons Committee on Trauma establish acceptable rates for these failures.
Okay.
For under triage, the acceptable rate is less than 5%. That makes intuitive sense. You absolutely do not want to send a patient with a lacerated spleen to the waiting room.
Right. A 5% failure rate on missing critical injuries seems reasonable. But to keep that number so low, what does the over triage rate have to be?
To achieve an under triage rate below 5%, standard trauma guidelines accept an over triage rate of 35 to 50%.
Wait, let me just pause on that number. Up to 50%.
Yes, up to 50%.
So you are telling me that on any given Tuesday, half of the people being rushed into level 1 trauma centers as highest priority might not actually need that extreme level of instantaneous resource allocation?
Yeah, that's exactly right. Some epidemiological models and investigators of trauma triage rules even argue that an over triage rate of 50 to 60% is a necessary baseline.
Just to keep the under triage rate hovering around 10%.
Exactly. In a standard, fully functioning civilian trauma system, we deliberately err heavily on the side of caution. We purposefully over-resource.
We send the helicopter, we activate the trauma team, we prep the OR, all to ensure that nobody slips through the cracks.
It makes total sense when you map it onto other industries, honestly. Think about an airline purposefully overbooking a flight.
Oh, that's a great analogy. They know, statistically, that 10% of people are going to miss their connection or cancel at the last minute.
Right. So they sell 110 tickets for 100 seats to ensure the plane flies full.
And that system works perfectly on a normal day. It's an accepted inefficiency.
All right.
But if a massive holiday blizzard strikes, every other airline shuts down, and all 110 ticket holders actually show up to the gate demanding their seat simultaneously, the system instantly collapses.
Exactly. The math that works on Tuesday creates a riot on Friday. That is a phenomenal way to visualize it.
Because that 50% over triage rate works beautifully when you have a couple of isolated car crashes on the interstate. The hospital absorbs the false positives easily.
But now, apply that exact same mathematical baseline to a mass casualty incident, an earthquake, for example.
Let's run the numbers on that.
Say a severe earthquake hits a metropolitan area, yielding between 1,000 and 2,000 immediate casualties.
Okay, that's a massive influx.
If the emergency medical services on the ground maintain their normal 50% over triage rate, meaning they are tagging people as immediate priority just to be safe, they are suddenly generating hundreds and hundreds of false reds.
False reds, meaning hundreds of people flagged for immediate life-saving surgery who don't actually need it right this second.
Yes. You would instantly generate between 100 and 200 false reds.
And those would be mixed in with the 200 to 400 true reds who legitimately are bleeding to death.
Right. That combined number of high-priority patients arriving simultaneously would completely overwhelm the physical space, the personnel, and the supply chains of even the largest, most advanced urban hospital networks in the world.
The doors would be blocked, the surgeons would be paralyzed by the sheer volume, the system just breaks.
So the very math that protects patients in everyday trauma care becomes the exact mechanism that destroys the hospital during a mass casualty event.
Wow. Which leads us to the most difficult ethical pivot in disaster medicine.
It does. During a massive crisis, the triage officers have to dynamically rewrite the rules of sorting on the fly.
As the expected number of casualties rises, they have to actively and aggressively work to reduce the rate of overtriage. They have to stop being so cautious.
And the terrible reality is that to reduce overtriage, you have to knowingly accept a higher rate of undertriage.
That is just, wow. So you have to willingly increase the risk that you might accidentally send a dying person to the waiting room just to protect the hospital's core infrastructure from collapsing under the weight of false alarms.
You do. And the clinical doctrine acknowledges how heavy this is. For instance, in planning for catastrophic earthquakes with casualties in the tens of thousands, logistical models suggest some grim realities.
Like what?
They suggest that victims who only have a 50% chance of survival, a literal coin flip, might need to be initially bypassed.
We will get into the specific color tag shortly, but essentially, if resources are stretched that thin, you cannot tie up a mechanical ventilator and a team of 4 nurses for 6 hours on someone with a 50-50 shot.
Exactly. You have to allocate those same resources to save 5 people who have an 80% chance of survival.
That is an incredibly heavy burden to place on human shoulders.
It is.
And to really understand how humanity developed these mathematical rules of sorting and how we arrived at these intense ethical frameworks, we can't just look at modern hospitals.
No, triage wasn't invented in an air-conditioned boardroom or a university ethics class.
It was forged in the absolute worst conditions imaginable. It was born on the bloodiest battlefields in human history.
It absolutely was. The history of military medicine is essentially the history of triage, and it goes back so much further than most people realize.
How far back are we talking?
The very first documented instance of humans systematically prioritizing patients by their prognosis dates back to the 17th century BC.
You're talking about the Edwin Smith Papyrus, right?
Yes, an ancient Egyptian medical text recovered from a tomb in Thebes. It is widely considered the oldest known surviving trauma manual in history.
That's incredible.
It was likely used by military surgeons, and what makes it so revolutionary is its rational, non-magical approach to injury.
Thousands of years ago, these ancient physicians were already categorizing injuries based on the likelihood of survival.
Right. They divided patients into 3 distinct groups. An ailment they would treat, an ailment they would contend with, meaning they would try, but the outcome was uncertain.
And an ailment not to be treated because it was universally fatal.
Exactly. It's stunning that the core logic of triage was already established in 1700 BC.
But the modern framework, the operational system we would actually recognize today, that didn't solidify until the Napoleonic Wars, right? Enter Baron Dominique Chanleray.
Baron Larry is arguably the most pivotal figure in the history of trauma response. He was the chief surgeon in Napoleon's Grand Army in the late 18th and early 19th centuries.
What was battlefield medicine like before him?
Before Larry, battlefield medicine was essentially a post-battle cleanup operation. Soldiers lay where they fell in the mud until the fighting stopped.
Which often meant bleeding out from completely survivable wounds.
Right. And if you did get treated, it was based strictly on your military rank and your nationality.
So an officer with a sprained ankle got a bandage before an enemy soldier, or even a low-ranking friendly soldier with a severed leg.
Oh, which, from a medical standpoint, is completely absurd. But Larry flipped that entirely on its head.
He instituted a paradigm shift that shocked the military establishment. He invented the flying ambulance, horse-drawn wagons that would literally gallop onto the active battlefield to retrieve the wounded while the fighting was still happening.
And, more importantly, he established the rule that the wounded must be treated strictly according to the gravity of their injuries.
He explicitly wrote that it is necessary to always begin treating the most dangerously injured first, completely ignoring their rank, their social status, or what flag they fought under.
That is a profound moment in medical ethics. the transition from treating the uniform to treating the wound.
And then you move forward to the mid-19th century, around 1846, with John Wilson, a British naval physician. If Larry said, treat the worst injuries first, Wilson added the next crucial layer of logic.
Wilson recognized the reality of limited resources on a warship. He recommended that casualties with minor injuries should be deferred, which makes sense.
But he also instituted the rule that patients with fatal, non-survivable injuries must also be deferred.
Right. The priority, the immediate focus of the surgeon, had to be strictly on the severely injured who could actually be saved by intervention.
It is the exact same math we are wrestling with today. Who can wait, who is beyond saving, and who needs the knife right now?
And this philosophy gets put to the ultimate industrial test during World War I.
The sheer scale of the artillery and trench warfare forced French doctors to codify these concepts into strict operational doctrine at the aid stations.
The volume of casualties in World War I was unprecedented, and the French formalized triage into three distinct, highly pragmatic categories.
What were they?
First, soldiers who were expected to live, regardless of whether they received care at the aid station. Second, soldiers who were expected to die, regardless of the care provided.
And third, soldiers for whom immediate surgical care would make a definitive life or death difference.
The middle ground. The patients where the medical intervention is the actual fulcrum between life and death.
Precisely. And from there, military triage evolved at a breakneck pace through World War II, the Korean War, and the Vietnam War.
The major variable that changed in those mid-century conflicts wasn't necessarily the surgery itself, but the transportation, the logistics of the evacuation chain.
Right, the introduction of the helicopter, the dust-off flights in Vietnam, and the MSH units in Korea.
The use of rotary wing aircraft fundamentally altered the physiological outcomes of trauma.
By rapidly airlifting patients out of the combat zone directly to specialized mobile surgical hospitals, the military proved that proper field triage combined with rapid evacuation saves lives.
They managed to compress the elapsed time from the moment of injury to the moment of definitive surgical care to less than 2 hours.
And it's fascinating how that military necessity eventually bled into our civilian infrastructure. Because prior to the 1970s, civilian trauma care in the U.S. was pretty chaotic, wasn't it?
It was. If you got into a horrible car crash, the ambulance just took you to the nearest local hospital, regardless of whether they had a trauma surgeon on staff.
But as doctors returned from Vietnam, they realized that the civilian world needed a system.
They realized that severely injured patients treated at dedicated specialized trauma centers had vastly superior survival rates.
But just like in a mass casualty event, you cannot send every single stub toe, minor laceration, or fender bender whiplash to the level 1 trauma center, or the specialized surgeons get overwhelmed with minor cases.
The under-triage and over-triage math again.
Exactly. So in the late 70s and 80s, civilian pre-hospital trauma triage systems were developed.
They analyzed vast databases of trauma registries to create field triage decision rules. They needed formal, objective scoring systems so paramedics in the field could accurately sort patients to the correct level of care,
preventing the overburdening of urban trauma centers. Now, while the civilian world was building that infrastructure based on the golden hour, the idea that you have 60 minutes to get a severely injured patient into an operating room, the military kept pushing the boundaries.
They did. The current military doctrine doesn't even talk about the golden hour anymore. They talk about the platinum 10 minutes.
The platinum 10 minutes. That represents a massive evolutionary leap in trauma response.
In modern asymmetrical conflicts, the weaponry is so devastating that you simply do not have 60 minutes. If an improvised explosive device severs an artery, the patient will bleed to death in 3 minutes.
So the goal is no longer just rapid transport. The goal is rapid triage and immediate life-saving intervention at the point of injury within 10 minutes.
We're talking about applying tourniquets, packing wounds with hemostatic dressings, and performing needle chest decompressions right there in the dirt under fire.
To buy that casualty the physiological time they need to survive the helicopter ride to a forward-deployed surgical unit.
Exactly.
Now, if the military has perfected this logistical chain to the point where, and this statistic is just staggering, there is a 98% survival rate amongst combat casualties who reach a surgical facility today. Why is it so incredibly difficult to replicate that level of success in a major civilian city during a disaster?
If we know how to do it in a war zone, why does a civilian hospital struggle so much?
Yeah, Exactly.
It is a brilliant question, and the answer comes down to a concept the military calls MEDRO, medical rules of engagement.
Medro. Okay, explain that.
In a military theater of operations, the command structure dictates the entire range of care based on the specific mission, the tactical reality, and a completely known inventory of resources.
So the military controls the environment.
They do. They project casualty rates in advance. They have strict, unbreakable chains of command. And most importantly, they secure the evacuation routes.
Oh, I see. A civilian city during a disaster is the exact opposite of a controlled environment.
It is pure anarchy. Roads are immediately blocked by civilians trying to flee, by traffic accidents, by debris.
The police are overwhelmed, so the routes are not secured.
Furthermore, civilian hospitals operate as independent entities, not as a unified military command.
Yeah.
They function under day-to-day normative rules that are highly resistant to the brutal, population-centric math of triage.
So the military succeeds because they impose rigid control over the entire ecosystem of care. Civilian disaster response often fails because it is reacting to an ecosystem it cannot control.
Precisely. Which is why having a universal language of triage is so critical. History explains why we have to sort patients, but modern doctrine is incredibly specific about exactly how we categorize them in the field.
And it is done using a universal color-coded tagging system. This is the visual language of disaster response. Let's break down the 4 colors of survival.
The internationally recognized standard system utilizes 4 main tags. Immediate, which is red, delayed, which is yellow, minimal, which is green, and expectant, which is black.
And it's vital to understand the precise physiological criteria for each, because assigning these colors is a clinical decision, not a guess.
Absolutely. It's highly clinical. Let's start at the top of the priority list with red, the immediate tag.
These are the patients who require life-saving medical attention within minutes to a maximum of 2 hours upon arrival to avoid death or major irreversible disability.
The key phrase here is that these patients have a high likelihood of survival, but only if they get immediate intervention.
Right. The red tag is for catastrophic but fixable physiological cascades.
The clinical guidelines provide very specific examples: an airway obstruction or a severe maxillofacial injury that threatens to occlude the airway. If they can't breathe, they die in minutes.
Another classic red tag is attention pneumothorax. Let's actually define that because it sounds like jargon, but it's physically terrifying.
It really is.
Attention pneumothorax is when a wound to the chest acts as a one-way valve. Air gets sucked into the chest cavity when you inhale, but it can't escape when you exhale.
Right, so the air pressure builds up inside the pleural space, completely collapsing the lung.
Yeah.
But it doesn't stop there.
It gets worse.
Much worse. The pressure continues to build until it physically pushes the entire mediastinum, the heart, the trachea, the major blood vessels, over to the opposite side of the chest.
Oh, wow. So it compresses the superior vena cava, meaning blood can no longer return to the heart?
Exactly. The heart is pumping empty. It leads to profound obstructive shock and cardiac arrest very quickly.
But if a medic simply inserts a needle into the chest wall to vent that trapped air, the pressure releases and the patient's life is saved instantly.
It's the ultimate red tag scenario.
Yeah.
Imminent death without intervention, rapid survival with it.
Other red tag criteria include a threatened loss of a limb due to ischemia, multiple extremity amputations, uncontrolled hemorrhage, or severe injuries to the torso, neck, or pelvis that are accompanied by profound shock.
Basically, if they don't get a tourniquet, an airway, or a trauma surgeon immediately, their physiology will collapse.
Then you step down to the yellow tag, the delayed group. Now, delayed is a bit of a misnomer to the public. These are not minor injuries.
No, not at all. These are severely wounded individuals who absolutely will require surgical intervention. But their current physiological state is stable enough that their treatment can be delayed for hours without immediately endangering their life, limb, or eyesight.
So they need sustaining, temporizing treatment while they wait in the queue. They need IV fluids, they need broken bones splinted, they need antibiotics, and they need pain control.
Right.
What specific injuries fall into this yellow category?
We are looking at significant trauma that hasn't yet caused massive systemic shock. Blunt or penetrating torso injuries, where the patient's blood pressure is holding steady.
Severe soft tissue injuries that don't have massive, uncontrolled arterial bleeding.
Yes. Facial fractures, where the airway is completely clear and unthreatened. Open or closed bone fractures. Eye globe injuries.
Or survivable, moderate-degree burns that don't threaten to swell and close off the airway.
They are badly hurt. They definitely need the operating room, but they can safely wait on a stretcher while the surgical teams work on the red tags.
Then we have the green tag, the minimal group. These are colloquially known as the walking wounded.
Yes, the green tags have minor injuries. Lacerations that require a few stitches, superficial abrasions, small fractures of the fingers or toes, minor burns.
They are physiologically completely stable. They can effectively care for themselves, or they require only very basic first aid.
In fact, in a military or austere environment, doctrine often suggests utilizing the green tag casualties as a manpower resource.
Really? Having them help out.
Yeah, having them help carry litters, apply pressure to other patients' wounds, or distribute supplies.
Now, conceptually, you would assume that the massive bleeding red tag injuries are the biggest threat to a hospital's capability during a disaster.
You would think so.
But when you look at the logistical data of past civilian mass casualty incidents, there is a massive paradox regarding the green tags.
It is one of the most dangerous phenomena in disaster response. Here's where it gets really interesting.
Okay, lay it on me.
If a mass casualty event, say, an explosion or a train derailment occurs in close geographical proximity to a major medical treatment facility, the green tags become a critical logistical nightmare.
Because they can walk.
Precisely. They are terrified, they are hurt, and they still have the physical mobility to flee the scene. They do not wait for the fire department.
They do not wait to be formally triaged by EMS and loaded into ambulances. They simply walk, run, or get driven by bystanders and private vehicles directly to the nearest hospital.
They completely bypass the established casualty evacuation chain.
Which means a mob of hundreds of panicking, bleeding, but non-critical people suddenly flood the emergency room doors all at once.
They inundate the facility. They physically block the ambulance bays. They grab the attention of the triage nurses demanding care.
And if the hospital hasn't immediately locked down its perimeter, those green tags will cause an early massive commitment of resources.
Bandages, beds, personnel time all burn through before the first ambulance carrying a critical red tag patient even arrives.
It's a literal traffic jam of minor injuries blocking the door to the trauma bays.
Which is why the operational guidelines stress that it is absolutely vital for a hospital to deploy security, lock down the facility, and establish an external triage choke point the absolute second they are notified of an event.
Strictly to prevent the green tags from unknowingly crashing the system.
Exactly. And then finally, we must discuss the most difficult, the most ethically fraught category in all of medicine, the black tag.
The expectant group.
Yes. These are the patients whose injuries are so overwhelmingly severe that their survival is highly unlikely.
And committing the massive amount of resources required to try and save them would directly result in the deaths of multiple salvageable red tag patients.
The clinical criteria for a black tag are grim, and they represent devastating physiological trauma, a casualty arriving with no vital signs or signs of life.
A transcranial gunshot wound, meaning the bullet crossed the hemispheres of the brain, accompanied by a deep coma.
High spinal cord injuries that paralyze the diaphragm and prevent breathing. Massive open pelvic fractures presenting with class 4 shock.
Meaning they have already lost more than 40% of their blood volume and their heart is failing.
Or extensive third-degree burns covering the vast majority of their body surface area.
I think it is so deeply important to pause here and clarify the ethical instruction regarding the black tag. Tagging someone as expectant does not mean abandonment.
No, absolutely not, and the doctrine is explicit about this.
It is not in order to turn your back on a human being and let them suffer.
Expectant casualties should be separated from the view of the other trauma patients to reduce psychological trauma for everyone, but they must be intermittently reassessed in case resources suddenly free up.
More importantly, they require dedicated staff capable of providing palliative care, administering massive doses of pain medication, and providing comfort measures in their final moments.
The psychological weight of handing out a black tag is immense.
I can't even imagine. You are an emergency physician trained your entire life to fight death, and you are actively deciding to stop fighting because the math of the population demands it. You are accepting one death to buy 3 lives.
Which is why the process of assigning these colors cannot be based on a doctor's gut feeling or emotional intuition.
Right. Doing this accurately in the dark, in the freezing rain, or in the chaotic aftermath of an explosion requires strict, unbreakable methodologies.
And this brings us to one of the most fascinating debates in disaster medicine.
The protocols outline 2 wildly different philosophies on how exactly a responder should assign these tags: rigid algorithms versus mathematical scoring systems. Let's pit these 2 methodologies against each other.
Let's start with the rigid algorithms, because they are the most common.
Okay.
The most famous algorithmic system, widely utilized across the United States, Canada, and parts of Australia, is START. That stands for Simple Triage and Rapid Treatment.
It was developed back in the 1980s by Hoag Hospital and the Newport Beach Fire Department in California.
That's the one.
Hmm.
And the entire design philosophy of START is speed. It is engineered to be executed by a first responder in 60 seconds or less, preferably aiming for 30 seconds per patient.
It strips away complex clinical judgment and replaces it with a rigid yes or no flowchart based on a few very specific physiological markers.
Right. It evaluates a sequence, often remembered by the acronym RPM, respiration, perfusion, and mental status.
Let's walk through it. A paramedic approaches a victim. Step 1. Can you hear me? Can you walk over to that tree?
If the victim gets up and walks, they automatically get a green tag. They're moving, breathing, and following commands. Assessment over, move to the next person.
But if they cannot walk, you move down the flowchart to respiration.
You check their breathing. If they are not breathing, you manually open their airway. If they still don't breathe, black tag.
But if they do start breathing, or if they are already breathing, you count the rate. Is their respiratory rate over 30 breaths per minute?
And the physiological logic there is that a respiratory rate over 30 extreme tachypnea indicates that the body is desperately trying to compensate for profound hypoxia or severe shock.
Exactly. So if the rate is over 30, boom, red tag. Stop assessing, tag them, move on.
If the rate is under 30, you move to the next step, perfusion. You check capillary refill by pressing on their fingernail bed until it turns white, and then seeing how fast the pink color returns.
Which measures peripheral blood flow. If the body is bleeding heavily internally, it shunts blood away from the fingers to protect the core organs.
Right, so if the capillary refill takes longer than 2 seconds, or if you can't feel a radial pulse at the wrist, that means their blood pressure is critically low.
Boom, red tag, move on.
And finally, if their breathing is under 30 and their pulse is okay, you check mental status. You ask them to obey a simple command like, squeeze my hand.
If they cannot obey the command, it means their brain isn't getting enough oxygen. Red tag.
If they can squeeze your hand, they get a yellow tag.
It is a brilliantly simple, highly effective decision tree, and there are necessary variations of it. For example, there is Jumpstart, designed specifically for pediatric patients, generally children under the age of 8.
Because you can't use adult physiological markers on a toddler. A crying 2-year-old might normally breathe 30 times a minute.
And they certainly are going to follow a command from a stranger in a scary uniform.
Exactly. So Jumpstart modifies the respiratory thresholds and uses the AVPU scale, checking if the child is alert, responds to verbal stimuli, responds to pain, or is unresponsive to judge their neurological status instead of asking them to follow commands.
And there are other algorithmic variations globally. The CIV algorithm in Europe uses slightly different respiratory cutoffs.
The CareFlight system in Australia changes the order, checking mental status before respiration.
There is the SALT system, sort, assess, life-saving interventions, treatment/transport, promoted heavily by the CDC, which integrates rapid interventions like applying a tourniquet directly into the flowchart steps.
The primary advantage of all these algorithmic systems is their cognitive simplicity. In a high-stress, terrifying environment with dozens of screaming casualties, adrenaline destroys a responder's higher cognitive functions.
You need a system that relies on gross motor skills and binary yes or no questions. It is incredibly easy to train a massive force of firefighters, police officers, and soldiers to use START.
But the very simplicity that makes it fast is also its biggest weakness. It is entirely inflexible.
That is the critical flaw. Algorithms inevitably lead to massive over-triage.
An algorithm like START is completely blind to the environment. It doesn't know if you have a fleet of 50 ambulances waiting, or if you are trapped on an island with 0 resources.
It rigidly assigns a red tag based solely on a fixed physiological number.
Which brings us to the alternative philosophy, mathematical scoring systems. These reject the binary flowchart in favor of calculating probability.
They look at systems like the Revised Trauma Score, or RTS. The RTS calculates a numerical score from 0 to 12 by mathematically combining the patient's Glasgow Coma Scale score, their respiratory rate, and their systolic blood pressure.
And that resulting number correlates directly to statistical mortality. An RTS of 12 predicts a survival rate of over 99%, while an RTS of 5 predicts a 50% mortality.
The military even adapted this into the field triage score, because trying to hear a blood pressure cuff in a noisy, chaotic combat zone is nearly impossible.
So they simplify the math by just using the motor component of the coma scale and checking for the simple presence of a radial pulse.
But the most advanced, mathematically elegant system highlighted in the disaster doctrine is the Sacco triage method, or STM.
SACO is fascinating because it isn't just a clinical score. It is a dynamic operations research model driven by outcome probabilities and real-time resource availability.
The Sacco method was developed in the aftermath of the September 11 attacks, and it completely shifts the paradigm.
It uses a physiological scene score based on respiratory rate, pulse rate, and motor response to accurately predict the victim's exact mathematical probability of survival.
But the genius of Sacco is that it takes that survival probability and cross-references it against the specific resources you actually possess at that exact moment, the capabilities of the receiving facilities, and the projected timeline for transport.
Let's put these two systems, START and SACO, head-to-head in a real-world scenario to really illustrate the difference.
Good idea. Imagine a victim of an explosion. They are breathing incredibly fast, let's say 40 breaths per minute. They have a
Okay, under the rigid START algorithm, the paramedic evaluates respiration first. The moment they see the patient breathing 40 times a minute, they immediately stop assessing.
The flowchart says anything over 30 is a red tag. The patient is instantly categorized as immediate priority, regardless of any other factors.
But under the SACO mathematical model, the medic calculates those same vital signs and derives a SACO score of 9. And mathematically, across vast databases of trauma records, a patient with a score of 9 has a 90% probability of survival.
So the Sacco model looks at the situation and says, wait, this patient is actually highly likely to survive their injuries. If our hospital is currently overwhelmed, perhaps they should not receive a red tag.
They shouldn't be allowed to monopolize the immediate life-saving surgical suites that might be desperately needed for a patient who only has a 20% chance of survival without immediate intervention.
It is the difference between a fast food drive-thru and a master chef in a high-end kitchen. The algorithmic START method is the drive-thru. It is inflexible, it is incredibly fast, it processes massive crowds efficiently, but you get exactly what is on the menu, no exceptions.
The SACO scoring system is the master chef. It is highly accurate. It constantly adjusts the recipe on the fly based on the exact ingredients available in the pantry that night, resulting in much less waste and significantly reduced over-triage.
But it requires intense, highly specialized, continuous training to execute properly.
And that fundamental tension speed versus accuracy, simplicity versus resource awareness is exactly why there is no single, universally agreed-upon triage system globally.
In fact, comprehensive reviews sponsored by the CDC have concluded that there is insufficient evidence to unequivocally declare one system superior to the others in all situations.
You have the Spanish Meta system, which incorporates advanced trauma life support protocols. You have the TWS system in South Africa, which factors in body temperature.
You have the CRAM scale evaluating speech and abdominal tenderness. It is a fragmented landscape because every specific geographic and operational environment demands a different compromise between speed and precision.
Now, all of these systems we just debated, START, SACO, SALT, CIV, they were entirely engineered for traditional kinetic trauma. Bombs, bullets, building collapses, multi-car pileups, broken bones, traumatic brain injuries, and bleeding.
But what happens to the mathematical models of triage when the threat isn't kinetic? What happens when the threat is microscopic or invisible?
This brings us to a really sobering reality of modern disaster medicine: unprecedented crises. The established doctrine acknowledges that our standard triage categories simply break down and fail to fit certain specialized scenarios.
You're talking about asymmetric threats like biological or chemical warfare agents, or even a scenario where a patient has unexploded ordnance physically embedded in their body.
Exactly. In traditional triage, you evaluate a critically injured patient, you slap a red tag on them, and you rush them into a crowded emergency room.
But if that patient is covered in a weaponized nerve agent, or infected with a highly contagious hemorrhagic fever, or has a live grenade lodged in their thigh, they pose a direct lethal risk to the other casualties, to the highly trained medical personnel, and to the structural integrity of the facility itself.
You cannot bring them inside.
The logistics invert completely. When a patient with a gunshot wound enters a hospital, the gun is gone. The threat is over. But when a patient with a biological agent enters a hospital, The weapon is still actively deploying.
And the most profound modern example of this systemic breakdown was the COVID-19 pandemic.
Yeah, that's true.
In early 2020, this novel coronavirus overwhelmed medical infrastructures across the entire globe simultaneously. It created an exponential, sustained demand for critical care and respiratory surge capabilities that lasted not for hours, but for months.
It forced the implementation of desperate triage protocols specifically aimed at determining the allocation of mechanical ventilators.
Looking at how hospitals reacted, it's clear that the pandemic fundamentally shattered the traditional trauma triage paradigm.
In a battlefield mass casualty event, the threat is an external finite event. A bomb went off. The patient is solely a victim of that event.
But in a severe pandemic, the patient themselves becomes the vector. They pose a risk to the staff treating them. And the wound isn't an artery you can clamp or a lung you can decompress. It's an invisible viral load that attacks the respiratory system over weeks.
Because it was a completely novel threat, and because there was often a severe lack of centralized national guidance during the initial waves, hospitals around the world were forced into an impossible position.
If we connect this to the bigger picture, they had to institute independent, autonomous triage protocols. Individual hospital ethics committees were quite literally writing the rules of life and death on the fly, trying to adapt to a reality where the standard algorithms provided no answers.
And reading the historical documentation of those decisions, it became incredibly fraught. The reality of resource scarcity forced many medical systems to adopt non-clinical criteria for triage.
You saw regions using strict age cutoff values to unilaterally withhold advanced life support.
You saw the implementation of social utility criteria, where healthcare professionals or essential workers were prioritized for ventilators under the logic that saving them would allow them to save others.
In some overwhelmed areas, the complex math was abandoned entirely, and they reverted to a desperate first-come, first-served policy simply because they couldn't process the ethical burden anymore.
The moral injury inflicted on medical personnel during those times is immeasurable. They were forced to shift from traditional clinical triage, where you evaluate physiology and ask who can survive, to deeply uncomfortable social utility triage, asking who is most valuable to society.
We aren't here to debate the philosophical rightness or wrongness of those impossible pandemic policies, but it is an undeniable objective fact that when a threat is invisible, systemic, and prolonged, the traditional START algorithms and the SACO resource models completely disintegrate.
It really emphasizes that whether you are facing a novel microscopic virus, an active shooter scenario, or an earthquake, surviving these extreme system-breaking scenarios ultimately comes down to one core concept: relentless, obsessive preparation.
You cannot wait for the disaster to strike to figure out your triage matrix.
You absolutely cannot. Which brings us to the critical challenge of translating the military's battlefield success into the civilian world. How do we take that 98% survival rate from the combat zone and apply it to an urban hospital network?
Well, the military operates on a very simple, unyielding motto: train as you fight.
The doctrine emphasizes that military medical units do not just read about triage, they physically simulate it constantly. They incorporate complex variables into massive simulation scenarios that involve entire bases, moving actual people around, dealing with simulated communications failures, and resource depletion.
The frequency of this training is what separates them. The average military triage training evolution lasts 2 hours, and they execute it 3 times a week.
Let that sink in. 2 hours, 3 times a week. Just physically practicing the sorting of mass casualties over and over until the cognitive load is reduced to muscle memory.
That intense commitment to procedural memory is exactly why they succeed when the real chaos hits. Now compare that to civilian mass casualty events. Analyses of recent civilian disasters highlight a stark contrast in preparedness.
Look at the Boston Marathon bombing response compared to the tragic Las Vegas shooting or the 9/11 attacks on the Pentagon.
The Boston Marathon response is often cited as a triumph of medical logistics, but that wasn't an accident.
It wasn't an accident at all. In Boston, because it was a massive planned event, multiple specialized EMS teams were already deployed on standby. But far more importantly, the city planners had already mapped, blocked off, and secured the physical routes from the marathon finish line to the various Level 1 trauma centers.
So without realizing it, they had artificially created a military-style medro. They had established a secured, controlled operational environment before the explosion happened, which allowed the ambulances to move freely and distribute the casualties evenly across multiple hospitals.
Exactly. Now contrast that level of environmental control with the Las Vegas shooting Or the Pentagon on 9/11, where ambulances were utterly paralyzed by civilian traffic, fleeing crowds, and unmitigated chaos.
The primary lesson for civilian disaster planners is that possessing empty hospital beds is completely meaningless if you cannot reproduce the logistical contingency plans necessary to decompress overwhelmed facilities.
If you have a world-class surgical suite open across town, it is useless if you don't have the secured transportation route to get the right red tag patient into it.
And within the hospital itself, who is acting as the conductor of this terrible orchestra?
Yeah.
Who is physically standing at the doors directing the traffic and making the calls? The operational guidelines refer to this role as the triage officer.
The triage officer is, without exaggeration, the most important single individual in a disaster response scenario. During combat operations, the military doctrine dictates that the surgeon on duty acts as the triage officer at Level 2 forward facilities, or the chief of trauma assumes the role at Level 3 hospitals.
They perform what is known as surgical triage. They are the ultimate gatekeepers.
And sometimes their role isn't even to fix the patient, but just to perform damage control surgery right near the front lines. They just pack the bleeding, stabilize the physiology, and act as a temporary bridge to get the patient to a larger hospital further back.
Yes. The focus is strictly on physiological stabilization, not definitive anatomical repair. And for civilian hospitals, the doctrine strongly recommends that the role of triage officer must be assigned to the most experienced, most senior clinician available.
It shouldn't be the newest resident. It should be the seasoned attending trauma surgeon. Furthermore, a hospital should ideally train at least 2 of them because the burnout rate is astronomical.
During a mass casualty incident, the mathematical expectation is that a triage officer must evaluate and categorize 10 patients every 20 minutes.
That is 1 patient every 2 minutes. Look at their breathing, assess their pulse, check their mental status, evaluate their injuries, and decide. Red, yellow, green, or black. Next patient. Over and over.
The psychological and cognitive pressure of that pace is staggering.
It requires a profound, intuitive understanding of emergency pathophysiology, an ability to rapidly project surgical outcomes, and a godlike awareness of exactly what manpower and equipment are available inside the building at that exact second.
They must be universally respected by the staff for their experience, their clinical judgment, and their leadership under unimaginably challenging circumstances. If the triage officer loses their nerve, the entire hospital falls.
And this brings up a brilliant operational point regarding the systems they choose to use. A hospital could theoretically adopt a highly sophisticated, mathematically complex, 5-level scoring system that perfectly balances resources and outcomes. But that system is completely useless and actually actively dangerous if the nursing staff and the paramedics haven't mastered it.
Exactly. The disaster doctrine emphasizes that a simpler, cruder, 4-level algorithmic system like START or SALT is vastly more reliable and effective than purely clinical judgment, provided the entire team has absolute mastery over it.
If an administrator forces a complex 5-level system onto a hospital staff, but the responders panic in the moment, or they miscalculate the mathematical scores because they haven't practiced it since orientation, you just create a secondary bureaucratic disaster on top of the physical mass casualty event.
Which is exactly why experts in the field heavily advocate for the concept of Triage Thursday. It's the recommendation that hospitals conduct brief, weekly tabletop exercises or physical drills to maintain disaster response skills, regardless of which specific system they have selected. You have to build the muscle memory.
So synthesizing everything we've analyzed is the ultimate lesson here that civilian hospital networks need to fundamentally change their disaster posture. Do they need to stop acting like traditional patient-centric civilian hospitals the moment a crisis hits and instantly snap into acting like population-centric forward-operating military bases?
Based on the evidence, yes. They have to embrace the Medro mindset. They have to push their perimeter out and establish secure triage stations outside the physical hospital building immediately, specifically to intercept and corral the green tag walking wounded before they breach the emergency department.
They have to empower their most senior, thick-skinned clinician to make rapid, absolute, unquestioned decisions at the door. And most importantly, the entire staff has to accept that triage is not a one-time stamp.
That is a crucial point. A patient's physiology changes. The hospital's resources deplete. A yellow tag who's been waiting for 2 hours might start bleeding internally and suddenly become a red tag.
A red tag who has been waiting for a surgeon that isn't coming might deteriorate to the point where they become a black tag. Failure to continuously reassess patients as the environmental conditions change is one of the major pitfalls that costs lives. Triage is a dynamic, continuous, unforgiving loop.
We have covered an immense amount of ground today. To synthesize this deep dive into a core takeaway for you listening, triage is a highly dynamic, mathematical, and deeply ethical sorting process that was forged in the fires of battlefield combat.
Whether a modern hospital utilizes incredibly rapid, rigid algorithms like start to quickly filter out the extremes, or they utilize complex, resource-aware numerical probability models like SACO, the ultimate goal is always exactly the same. They are trying to balance the dangerous seesaw mathematics of over-triage and under-triage to save the greatest number of human lives possible. And achieving that delicate balance requires relentless weekly training long before the sirens ever start wailing.
It truly is the ultimate test of both complex medical logistics and raw human endurance.
But I want to leave you with a final provocative thought to mull over, building directly on the inherent difficulty of that continuous reassessment loop we just discussed. We live in a heavily monitored, hyper-connected world where everyday consumer smartwatches and fitness trackers are constantly logging our real-time heart rate, our blood oxygen saturation, our body temperature, and even detecting if we've taken a hard fall. Are we rapidly approaching a near future where the chaotic, human-driven process of mass casualty triage becomes completely automated?
That is a fascinating and slightly terrifying technological question.
Right. Imagine a large-scale disaster. An earthquake hits a crowded city center. Instead of waiting for paramedics to arrive and manually check capillary refill on hundreds of victims, a centralized emergency AI instantly pings and pulls the live biometric data from the smartwatches and phones of everyone in the blast radius.
It runs a complex mathematical model vastly superior to SACO that factors in regional hospital bed availability, traffic patterns, and real-time physiology. It instantly assigns and constantly updates digital color tags on the victim's screens before the dust even settles.
From a purely mathematical standpoint, the over-triage problem could theoretically be eliminated instantly. The efficiency would be unparalleled.
But it leads to a much darker, much more profound ethical question. Will algorithms permanently replace the human triage officer? Or is the agonizing burden of deciding who gets the black tag, the decision to withhold life-saving care, a deeply fundamentally human responsibility? Is that a moral weight we can never and should never outsource to a machine?
Something to think about. Until next time, keep digging deeper.